This is Ashford. My name's Dr. Wells. Pleasure to meet you. I've been asked to examine your tummy if that's all right. First of all, can I just pull this down? That's all right. Can I just get you to undo your top two buttons? That's lovely. Just get you to cough me. There we go. Just start with your hands. Just turn your hands around for me. And back again. Just look up for me. And look down. And stick your tongue out. Trying to show your teeth. That's great. Just turn your head to the side. Just going to feel on you. Is there any pain in your tummy at all?
No.
Just going to have a feel of it. Just going to feel a bit deep. Deep breath in and out. And again, deep breath in. And out. Deep breath in and out. Just going to feel just in the line, just going to push. Can I just get you to sit forward for a minute? Just lift your brows. Just lovely. Nice, lift back down. I'm just going to have a look at your legs if I may. Is there any tenderness there?
No.
That's lovely, thank you very much. Shall I sit you up a bit?
Thank you.
All right. Mrs. Ashworth has chronic renal failure with renal replacement therapy, which is currently a transplanted kidney in the right iliac fossa. She has signs of chronic renal failure in the sense that she has widespread bruising, which would imply steroid usage as immunosuppressant therapy. She has gingival hypertrophy in keeping with cyclosporine therapy currently or previously. She does have a scar on her right forearm, which unfortunately I don't think is actually in keeping with an AV fistula in the past, because it's too high up and in the wrong place. However, she does have a thyroidectomy stroke parathyroidectomy scar on her neck. Implies she's potentially had autonomous hyperparathyroidism in the past, accumulating as a complication of her chronic renal failure. On abdominal examination, she has allotable masses bilaterally in keeping with polycystic kidneys. It's much easier to feel on the left hand side than the right hand side. However, on the right hand side there is a large scar where there is a renal transplant mass. This is non-tender and there are no bruises over there. The bowel sounds are normal. There is no other hepatosplenomegaly palpable. There is no signs of fluid overload in this lady, and she appears well and does not appear uremic, implying that the renal transplant looks like it's working very well. When you have an abdominal case, the potential likelihood is that you may have a renal patient or someone with hepatosplenomegaly due to hematological problems, or someone with chronic liver failure. So you start. It's important to make sure the patient's lying properly and is appropriately exposed. Very often patients have the t-shirts on, and it's important to take the t-shirts off. Now with Mrs. Ashworth, we left her bra on. If the bra is on normally, do ask to remove it. The examiners may stop you. Make sure the patient's appropriately clothed, and then but when you examine the abdomen, it's important to do that from the end of the bed, because if there are any scars, you need to look for a cough impulse and incisional hernias, for example, which may cause problems. Cover the patient up and start with the hands. The classical things in Mrs. Ashworth who has chronic renal failures are that she has generalized wasting of the small muscles of the hand. She has widespread thinning of the skin with widespread bruising in keeping with steroid usage. She has a scar on her right forearm, which is in the wrong place for a fistula. But it's important to look for these, and if they're not present, then to comment on them. If they are present and they're not, you can't feel a hum over them, to auscultate to see whether you can hear the hum. If it's an abdominal case, axillary examination and supraclavicular lymph node examination is important. Look in the mouth, not only for central cyanosis, but also for gingival hyperplasia, and look for anemia and jaundice. When you examine the neck, also look at the neck for any thyroidectomy and parathyroidectomy scars, which may give you a clue that the patient has chronic renal failure. When you examine the abdomen, if there is flank enlargement, very often implies that there is retroperitoneal mass, i.e. polycystic kidneys, for example. You examine your four quadrants. Always when you see scars, especially in the groinal area, examine them much more deeply to make sure that you're not missing a mass underneath them in keeping with a transplanted kidney. When you examine for the kidneys, anything that's blottable is retroperitoneal, and therefore is kidney until proven otherwise. Even if you think it's spleen, it's blottable, think about a large kidney. If you're not sure, percuss down to make sure that there is no liver, and also percuss along the line that the spleen descends to make sure there is no splenomegaly that you've missed. Very often you can lie the patient recumbent on the left side to feel for the spleen as well. When you're feeling for the spleen, lift the rib cage up to see whether you can go above it if you can palpate it. Auscultation over the kidney and for abdominal breast sounds as well as for bruise is important. To look for lymphadenopathy, especially if you felt splenomegaly is important as well. Look for fluid overload in your patients with chronic renal failure. Look at the back to ensure that there are no nephrectomy scars, and that's why in patients with a transplanted kidney you can't feel any polycystic kidneys, for example. The questions you're going to be asked in someone with chronic renal failure is the types of renal replacement therapies that you may come across, transplanted kidneys, tensional catheters, hemodialysis, for example. You're going to be asked about complications, bone complications, osteomalacia and osteoporosis should spring to mind, hyperparathyroidism, secondary and tertiary should spring to mind as well, and treatments of it as well as investigations of that. You may be asked about what therapies you can give, so immunosuppression, steroid, and gingival hyperplasia may imply cyclosporin, but also think about other immunosuppressant therapies like azathioprine and MMF as well, potentially in your patients. Also, there may be other sites of immunocompromisation like warts around the fingers, which may give the game away as you start examining the hands. Overall, in a patient, present the clinical findings, talk about your findings of renal replacement therapy being a kidney, comment on other renal replacement therapies that the patient may have undergone, and other evidence of complications that you may find, i.e. parathyroidectomy in this case, as well as potential therapies that the patient may be on.